So this is the 10th episode of the first season of Medicrew Masterclasses, the concluding episode with which we end the season on cardiovascular system. And let us summarize the clinical examination of cardiovascular system, the common pitfalls that we encounter during clinical examination, and some common tips of how to do it very smoothly. So as usual, we'll start with a few questions, and this is the first question for you. Normal range of pulse rate is. Next question. Irregularly irregular pulse is seen in. Next question. Bradycardia may be seen in. Next question. High volume pulse may be seen in. And finally, before we start the discussion, most distal pulsation is felt over. So let us start the discussion. We have already had a dedicated episode on arterial pulse. So I am not going to discuss in great detail the arterial pulse, but I will only overview the examination of arterial pulse because in general survey, that is one of the most important parameters that we see under cardiovascular system examination. While examining the pulse, it is important to note the rate of the pulse. And we know that the normal pulse rate is between 60 to 100 per minute. A pulse rate less than 60 is bradycardia, and a pulse rate more than 100 is tachycardia. Bradycardia can happen due to many reasons. The causes of bradycardia can be sinus bradycardia, where the SA node is generating impulse at a weaker rate. It can be caused by beta blockers like propranolol. It can be caused by certain specific types of calcium channel blockers like verapamil. This can be caused in obstructive jaundice, as bilirubin deposits on the SA node and therefore reduces the impulse generation. It can also be seen in certain specific types of AV nodal blocks. Tachycardia, on the other hand, can be seen in ectopic foci like atrial tachycardia, multiple ectopic foci like atrial fibrillation, abnormalities of the SA node like sinus tachycardia, and various other endocrine causes like thyrotoxicosis. It is important that we evaluate the rhythm of the pulse. The normal rhythm of the pulse is regular. When the pulse rhythm is irregular, it can be either a predictable irregularity, which is conventionally called regularly irregular, or it can be an unpredictable irregularity, which is called irregularly irregular. Regularly irregular pulse is seen in several important cases. For example, in constant ratio AV nodal block. Whereas irregularly irregular pulse is usually seen when there are multiple ectopics. And this is typically seen in conditions like atrial fibrillation. Fibrillation is always irregularly irregular. But be careful that ventricular fibrillation will not be a cause of irregularly irregular pulse. Fibrillation essentially means that the chamber is not contracting properly. And if the ventricle does not contract, there will be no pulse. So atrial fibrillation causes irregularly irregular pulse, whereas ventricular fibrillation can cause asystole or pulseless disease. After assessment of the rhythm, it is important to look at the volume. And volume refers to the amplitude of the pulse. So if this is the pulse wave, which we have also discussed in previous episodes, then the volume of the pulse refers to the amplitude of the pulse. That is the difference between the systolic peak and the diastolic trough. Quite obviously, this is proportional to the pulse pressure. So volume of the pulse increases whenever the pulse pressure increases, as in aortic regurgitation, in high fever, and in all other causes of hyperdynamic circulation. The pulse volume decreases when there is a narrow pulse pressure. That is, either the SBP falls or the DBP rises, which happens in hypovolemic and cardiogenic shock. In left ventricular failure, in cold exposure, when there is vasoconstriction. After assessment of the volume, it is important that we examine the patient's radioradial and radiofemoral delay. Delay is present when there is an unilateral obstruction to blood flow. So this can be due to coarctation of aorta. Coarctation means constriction. Or any physical compression that may be caused by thrombosis, some kind of a mass compressing on the blood vessel, or maybe a cervical rib. It is very important that while assessment of the pulse, we look into the character of the pulse. Character of the pulse means the waveform. So ideally, if we can record the waveform of the pulse by a technique called sphygmography, we can very well comment on the character. Otherwise, we can palpate a prominent artery like the carotid artery and try to imagine the character by feeling it with the tips of the finger. Look at the nature of the artery, the quality of the arterial wall. So the arterial wall may be normal, which is defined as just palpable, or even not palpable, or it may be abnormal, that is cord-like, which may be seen in atherosclerosis. So the rate, the rhythm, the volume, the character, delay and condition of arterial wall. These are the 6 most important points that we must look into while examination of the pulse. And it can give us a number of idea about the cardiovascular system setup. So let us try the questions that we started with. The normal range of pulse rate is. Wonderful. The answer is 60 to 100 per minute. Irregularly irregular pulse is seen in. Yes, the answer is atrial fibrillation. Bradycardia may be seen in. Wonderful. The answer is all of the above. High volume pulse may be seen in. Yes, the answer will be B, aortic regurgitation. The most distal pulsation is felt over. Yes, the answer will be arteria dorsalis pedis, which is the most distal artery. We'll now start with the next section, which is on the examination of the apical impulse or apex beat. Before we start the discussion, let's solve the questions. Apex beat becomes tapping in. Next question. Apex beat becomes forceful and well sustained in. Next question. Normal apical impulse is, so choose the correct option. Next question. So before we go into the next question, let's discuss about apical impulse. Now see, look at this animation carefully. You can see there is an obviously visible impulse here that is moving up and down. While it may not be so prominent in everyone, but this is this impulse that we call the apical impulse or the apex beat. How is it caused? This is caused by contraction of the left ventricle during systole. So during systole, the left ventricle does not just contract, it undergoes a spiral motion. And during that spiral motion, it strikes the anterior chest wall. When the left ventricle contracts and strikes the anterior chest wall, this kind of an impulse may be palpated or even seen in severe cases. And this is known as the apical impulse. So how do we conventionally define the apical impulse or apex beat? That is essentially what is apex beat. Let us see. So apex beat is defined as the outermost and lowermost point on the precordial. And precordium means the chest in front of the heart. So it is the outermost and lowermost point on the anterior chest wall that is just in front of the heart where a definite cardiac impulse can be felt. Where a definite cardiac impulse can be felt. So apex beat is the outermost and lowermost point on the precordium where a definite cardiac impulse can be felt. So the cardiac impulse must be definite and not vague. So what is the technique of feeling this apex beat? The technique of palpating the apex beat is that you place your palm over the precordium, that is the chest in front of the heart. Try to feel where the impulse might be located. Then further locate it with the ulnar border of the hand. And when you get an idea of where it might be, pinpoint it with your finger. So gradually we are narrowing down the area, that is first with the palm, then with the ulnar border of the hand, and then with the finger. And then mark it with a skin marking pencil. So this is the area of the apex beat. When we examine the apex beat, what is it that we are trying to investigate? When you are examining the apex beat, you are actually getting idea about the left ventricular systole. And you will describe your findings of apex beat under two headings: the position of the apex beat and the character of the apex beat. So when you place your hand over the precordium, you feel that a large portion of the precordium is pulsating or bouncing. Try to locate the point which is outermost, also lowermost, and it is still very prominent. Confirm that with the ulnar border, that is the margin of your hand. Once that is confirmed, then along the margin, try to feel what is the outermost yet definite point, and then locate that with the tip of your index finger. That is the position of the apex beat, or more specifically, that is the area where the left ventricle is striking during the systole. So what is the normal position of the apex beat? Normally, the apex beat is located in the left fifth intercostal space, half-inch medial to the mid-clavicular line. So if I annotate here, this is the clavicle. So the midpoint will be somewhere here, and if this is the clavicle, this is the mid-clavicular line. Of course, the person is not photographed in the horizontal position here. That is why the line is looking curved. And the position of the apex will be somewhere here under normal circumstances. Half-inch medial to the mid-clavicular line in the left fifth intercostal space. So if we draw the intercostal spaces, this is the position of the sternal angle, where the manubrium sterni and the body of the sternum join. And this corresponds to the second rib, below which is the second intercostal space. Then the third rib, third intercostal space. Fourth rib, fourth intercostal space. Fifth rib, fifth intercostal space. Sixth rib, sixth intercostal space. So accordingly, if you go, the normal position will be in the left fifth intercostal space, half-inch medial to the mid-clavicular line. So that is the normal position of the apex. Now, what is the normal character? The normal apex just lifts the palpating finger. That means it is neither very strong nor very weak. It will just feel like someone is elevating your palpating finger. So it just lifts the palpating finger. So this is the position and the normal character. However, under different circumstances, the position and the character of the apex beat might change. Let us discuss how the position of the apex beat might change. Now see, if we try to understand the position of the heart with respect to the patient, let us assume this is the thoracic cavity. This is the diaphragm. And the heart is located somewhere here. And this, let's assume, is the left ventricle. So if you see the surface marking, this is where the left ventricle is located. A portion of the left atrium comes in relation to this area. This whole area is the right atrium, and the inferior surface of the heart is composed of the right ventricle. This is how the chambers of the heart are actually located in the three dimensions. So if the left ventricle increases in size due to any reason, the heart starts growing obliquely in this direction. That is because the muscle fibers of the left ventricle are arranged in this direction. On the other hand, if the right ventricle increases in size, then the heart enlarges in this direction. That is again because the muscle fibers of the right ventricle are arranged in this direction and they grow like this. Which simply means that if there is a left ventricular hypertrophy, this will cause the apex to move downwards and outwards. Whereas if there is right ventricular hypertrophy, the apex will move only outwards and not downwards. The character of the apex might also change in different diseases. Whenever there is left ventricular hypertrophy, that is enlargement of left ventricle, apex becomes forceful. That is because the apex is caused by left ventricular contraction. So if the left ventricle enlarges, the apex will become forceful. Now, the duration of the systole depends on how long it takes the blood to go out of the ventricle. So, if there is an outflow obstruction, that is, blood cannot easily go out, that means there will be longer duration of the apex. And if there is an open outlet, then blood can easily go out, and therefore there will be a shorter duration of this whole episode. The contraction will be over very soon. Now, outflow obstruction means there is obstruction to blood flow. Blood is flowing into aorta. Outflow obstruction therefore happens in aortic stenosis. And an open outlet is seen in aortic regurgitation. In both cases, apex is forceful, but the durations vary. So what happens when the durations vary? In aortic stenosis, duration is short. So the apex will be best described as forceful. The duration will be long because it's taking longer time for the blood to come out. So it will be forceful and well sustained. And the other name for this is a heaving apex. In aortic regurgitation, it will be forceful, but the whole duration will be short lasting because blood can rapidly go out. And therefore, in aortic regurgitation, the apex will be forceful and ill sustained. And this sometimes is known as the hyperdynamic apex. If there is a narrowing of the mitral valve in mitral stenosis, we shall see later, then the first heart sound becomes very loud. Apex will be weak, but this loud sound can be felt with the hand. It's very much like if someone is knocking on the door, you can even place your hand on the door and feel the knock. So this kind of a knocking will be felt on the apex if there is mitral stenosis. So this loud sound can be felt with the hand, and this is known as tapping apex, as if someone is knocking on the chest wall. So tapping apex is characteristic of mitral stenosis. So we get a heaving apex in aortic stenosis, hyperdynamic apex in aortic regurgitation, and tapping apex in mitral stenosis. So I hope this is clear to everyone. So let us start with the questions that we started with. Apex beat becomes tapping in. What will be the answer? Very good. So apex beat becomes tapping in mitral stenosis. Apex beat becomes forceful and well sustained in. As it is well sustained, that means there is an outflow tract obstruction. And as it is forceful, that means there is a left ventricular hypertrophy. So the two things will happen together if the patient has aortic stenosis. So the answer will be A, aortic stenosis. Normal apical impulses. So which is the right option? Very good. The option is A, located in the left fifth intercostal space. The two other options are not correct. We now come to auscultation of the precordium, that is examining the precordium with a stethoscope. So let us see what are the questions that we have to face before we start the discussion. This is your first question for this section. First heart sound coincides with. Next question. Second heart sound is caused by. Next question. Third heart sound is caused by. Next question. Lower left parasternal heave is seen in. Next question. Epigastric impulse is seen in. Next question. thrill is. So what is a thrill? Aortic area is located in. Okay, I will come to this question much later. Let us first, I think there is a difference in nomenclature, it doesn't matter. Okay, aortic area is located in. Let's try this, no problem. Okay, so let us start the discussion. So this is a schematic representation of the different areas on the anterior chest wall or precordium. Let us first understand what these areas represent. The four areas that are named as mitral, tricuspid, aortic, and pulmonary, they do not represent the location of the valves. That is the first thing that we must understand. So mitral area is not the area below which there is mitral valve. Aortic area is not the area below which there is aortic valve. These areas represent those surface points on the precordium where sound from that valve is best audible. So in mitral area, the any sound produced in the mitral valve will be heard best. Doesn't necessarily mean that the mitral valve is just below that area. Similarly, in aortic area, the sound from the aortic valve will be heard best. It doesn't necessarily mean that the aortic valve is below that area. So these are not surface marking for the valves. These are the functional areas where sound from that particular valve will be heard best. So what are the four areas that we auscultate while examining the precordium? Let us first draw a schematic heart to illustrate the location of the different components. So this is a schematic outline of the heart. The mitral valve is present somewhere here, guarding the junction between the left atrium above and the left ventricle below. And the blood that flows from the left atrium to left ventricle moves in this direction, making the sound extremely audible in this particular point, which is same as the apex. So the position of the apex beat, the location of the apex beat is known as the mitral area. So in a person, if the apex beat has shifted, then the mitral area will also shift. The new apex will now become the new mitral area for that person. So mitral area is conventionally defined by the position of the apex, and that is where the sound from the mitral valve is audible best. Then comes the tricuspid area. The tricuspid valve is guarding the right atrium and the right ventricle, and the sound is best heard in this area with the valve located somewhere here. And because the sound is best audible in this area, so the tricuspid area is said to be located at the lower left parasternal region. That is on the left side, not on the right side. On the left side, just beside the sternum in the lower part. The intercostal spaces are vaguely defined, so it is the lower left parasternal region that is identified as the tricuspid area. Then comes the aortic and the pulmonary area. We all know that aorta arises from the left ventricle and pulmonary artery arises from the right ventricle. But if you look very carefully, see their positions are opposite. The aortic area is located in the second intercostal space beside the sternum, but on the right side. The pulmonary area is located in the second intercostal space beside the sternum, but on the left side. This is because that although the vessels are arising from their corresponding ventricles, they change directions. For example, the aorta arises from the left ventricle but turns like this with the arch of aorta. Similarly, the pulmonary artery or the pulmonary trunk, of course, arises from the right ventricle, but then this one also divides into two parts and turns. It is because of their turning, now you can easily understand the locations. At the point of this crossover, at the point of this turning, we are actually able to hear the sound best because they come closest to the precordium at these points. They become more superficial. That is why, although aorta is a left-sided artery, its sound is heard better on the right side. And the pulmonary trunk, although is a right-sided artery, its sound is heard better on the left side. So these are the four principal areas where precordial examination is done. So is this clear to everyone? Then I'll move on to the examination part. So what are the things that we examine in precordial examination? In precordial examination, we start with looking at the patient, which is called inspection. So we start with an inspection, and under inspection, we look for the shape of the precordium, presence of any scar mark, presence of any venous prominence, and if there is any visible impulse. Then we go on to touch the patient, which is known as palpation. Under palpation, the most important finding probably is examination of the apical impulse or apex beat. And under apex beat, you look for the position or location of the apex and the character of the apex. Sometimes abnormal sounds are produced in the heart, which are known as murmur. When a murmur is so loud that it can be felt with your hand, it is known as a thrill. So you also look for a thrill, which is nothing but a palpable murmur. And murmur is an abnormal sound that is produced in the heart. After palpation, we straightforward go to auscultation. And while auscultating the precordium, you auscultate all the four areas, taking good care to note the heart rate, the rhythm, heart sounds, and under heart sounds, you try to note the properties of first heart sound, second heart sound. If they are present, then the third and the fourth heart sound. And you also look for any abnormal or adventitious sound. For example, a murmur. So this is a very simplified scheme of examination of the precordial or the cardiovascular system. So let us see how the different components can be examined. Now, while examining the precordia, it's important that you first locate these four areas. And then, standing at the foot end of the patient, you look at the chest and see if you can see something significant. The normal shape of the precordium will be maintained if there is no congenital heart disease. In cases of congenital heart diseases, that is, heart diseases from birth, the shape of the precordium may be changed. So there may be precordial deformity. Look for scar marks that can indicate an injury, or it can also indicate a previous surgery. Look for venous prominence, which can indicate the presence of heart failure or venous obstruction. After these are done, you look for any visible impulse. Visible impulse means any pulsation in any part of the chest. So what are the areas that you should see? Check the apex. If there is a forceful apex, then there may be an apical pulsation. For example, in left ventricular hypertrophy. Look at the lower left parasternal region. In the lower left parasternal region, we have seen that the right ventricle is located. So, impulse may be present there in right ventricular hypertrophy. Look at the aortic area. If you see a pulsation in the aortic area, this may be due to aortic aneurysm. That is dilation of the aorta. Look into the pulmonary area. If the pulmonary artery is engorged with blood, a condition called pulmonary hypertension, then you may see some visible impulse in the pulmonary area. Look into the epigastrium, that is just below the xiphisternum. Sometimes the right ventricle can become so big that it can push the diaphragm below. And in those cases of severe right ventricular hypertrophy, you may get epigastric pulsation. Look into the interscapular area, that is in between the two scapulae, and you may find an impulse there in case of aneurysm of descending aorta. As the aorta is going down, if it is dilated abnormally, it will show a pulsation there. So these are some of the common areas where you can look for visible pulsation. Wherever you can get a visible pulsation, you will also get a palpable pulsation. Now, once this has been done, we will now get into the discussion of the palpation. We have already discussed apex beat, so I'm not repeating discussion on apical impulse here. Coming to any other possible pulsations that we can get, you look for the areas where visible pulsations can be seen, and you may also find a pulsation down there. For example, if you get a lower left parasternal impulse, you can also get a lower left parasternal heave, which is the palpatory finding. Now, coming to thrill, if you find that there is a murmur on auscultation, always make it a point to palpate that area. If a murmur is loud enough, it can also be palpated. And this palpable murmur is known as a thrill. Presence of a thrill means a murmur is a high-grade murmur. Then we come to the auscultation. In auscultation, we have to auscultate all the four areas and hear the heart sounds. Now, how are the heart sounds produced? All heart sounds are produced by three components: a valvular component, a vascular or flow component, and a muscular component. So what does it mean? For example, the first heart sound, is produced, we know, by the closure of the uh, atrioventricular valves. But then that is only the valvular component. So the valvular component of the first heart sound is closure of mitral and tricuspid valve. Additionally, some extra sound is produced by turbulence of blood. That is the flow component. And thirdly, the wall of the ventricle will also vibrate. So vibration or tension on the wall of the ventricle also causes the first heart sound. These three components join to produce the first heart sound. The first heart sound therefore has two valvular components, the mitral component called M1, one for the first heart sound, and the tricuspid component called T1. But they happen so simultaneously that they cannot be separately identified. So we never get two first heart sounds, we only get one first heart sound because the mitral and the tricuspid components overlap with each other. In contrast, if we now discuss how the second heart sound is created, it also has three components. The valvular component is closure of the aortic valve and pulmonary valve. However, it also causes turbulence of blood in the great vessels. Which is the flow or vascular component. And finally, there is also turbulence created on the wall of the blood vessel. So there is vibration of wall of the vessels, which is the muscular component here, the smooth muscle layer of the great vessels. Here again, therefore, the second heart sound has two components, one due to aorta called A2, 2 for second heart sound, and P2, the pulmonary component. However, they do not happen together. Usually A2 happens before P2, and the gap between these two is known as splitting of the second heart sound. So you actually hear two sounds side by side. So this is known as splitting of the second heart sound. The third heart sound, or S3, is produced by the rapid flow of blood during first rapid filling phase. Of course, with this comes the vibration of the muscle and flow of the blood as other components. Similarly, the fourth heart sound is caused by the second or the last rapid filling phase. That is atrial systole. So along with this comes the tension on the wall of the atrium and the sound of the flow of the blood. Now S3 and S4 are so feeble that they are not normally heard. They can only be heard in pathological conditions like in heart failure. Otherwise, we only hear the first and the second heart sound. Because first heart sound corresponds with the left ventricular systole, so this sound marks the beginning of systole. Similarly, the second heart sound marks the beginning of diastole. Because first heart sound corresponds with systole, it also coincides with the arterial pulse. The closest pulse to the heart is the carotid artery pulse. So sometimes we palpate the carotid artery while auscultating the heart. And the sound that corresponds with the carotid pulsation is the first heart sound. And the sound coming in between the two first heart sound is the second heart sound. That is the way to examine the heart sounds. So I hope this is clear to everyone. Let us try to solve the questions now. So first heart sound coincides with. Wonderful. All of the above is the answer. Second heart sound is caused by. Very good. Again, the answer will be all of the above. Third heart sound is caused by. Yes, the answer will be C, first rapid filling phase. Lower left parasternal heave is seen in. Very good. The answer will be A, right ventricular hypertrophy. Epigastric impulse is seen in. Yes, the answer is A, right ventricular hypertrophy. Thrill is. Yes, thrill is a palpable murmur. Aortic area is located in. Very good. The second intercostal space on the right side. Now we come to the final topic. It's a very brief topic, but it is often feared and confused of by students. That is why I chose this topic in the end. It is a component of the general examination of the patient and is known as the jugular venous pulse. So let us first try a few questions on jugular venous pulse before we explain the properties of the pulse. A wave on jugular venous pulse is caused by. Next question. C wave on jugular venous pulse is caused by. Next question. If the jugular venous pulse is 4 centimeter of blood, then the central venous pressure is. Next. Cannon waves in jugular vein are seen in. And the last question. Why descent is caused by. Okay, so let us discuss the jugular venous pulse. In certain conditions, you will see as given in this image, you can see there may be a visible purring of the jugular vein in between the two heads of the sternomastoid. So it is best seen than palpated. It is such a feeble pulsation that if you touch it, the pulse may be abolished. The best way is to illuminate it from the side and watch it from the side so that you can find out the trembling of the jugular vein. The upper part of the jugular vein will be trembling between two heads of the sternomastoid. Now, this pulsation is the jugular venous pulse, and the pressure of the blood is the jugular venous pressure. When you plot the pulsation, you see that it is a biphasic wave with the first phase having two notches. So altogether there are three positive waves and two downward descents or two negative waves. Let us first understand what causes this waveform of the jugular venous pulsation. The jugular vein or the internal jugular vein is continuous with the blood of the right atrium. So any pressure change in the right atrium is reflected on the blood pressure of the jugular vein. So the jugular vein is actually a manifestation of the events in the right atrium of the heart. The three positive waves are A, C and V, and I am using terminologies that will help you remember the mechanisms behind this. The A wave in jugular vein is caused by atrial systole. The C wave is caused when the ventricle is contracting during isovolumetric contraction and there is bulging of the tricuspid valve into the atrium. The bulging of the tricuspid valve causes a further elevation of the pressure. So it is caused by bulging of tricuspid valve at the beginning of ventricular systole. The V wave is caused by venous return. So when blood returns to the right atrium, the pressure rises. So it is caused by venous return. So you can easily remember this as the A wave is caused by atrial systole, C wave is caused by bulging of the cusp of a valve, and V wave is caused by the venous return. Soon after the atrium contracts, the atrium must also relax. So the X descent is caused by relaxation of the atrium, that is atrial diastole. And soon after the venous return, the tricuspid valve must open, so blood will go from atrium to the ventricle. That will cause the Y descent. So Y descent is caused by the opening of tricuspid valve and flow of blood from right atrium to right ventricle. So as the blood decreases, the pressure decreases. So this uprise is due to atrial systole. This fall is due to atrial relaxation. In the interim period, the sudden rise is due to bulging of tricuspid valve. The V wave is due to venous return to the right atrium. And the Y descent is due to emptying of the right atrium into the right ventricle. So are the phases of the jugular venous pulsation clear to everyone? So this is a summary of the events that we have discussed, and the jugular venous pressure is measured with the patient lying at 45-degree angle. This can be done with a pillow or with a bed rest. And you examine the uppermost point of pulsation of the jugular vein. Measure the height from the sternal angle, and this height is the jugular venous pressure. Normally, the jugular venous pressure must be less than 3 centimeter of blood. When it is more than 3 centimeter of blood, it is said to be elevated. Now, the sternal angle is 5 centimeter above the midpoint of the right atrium. And the pressure in the right atrium is known as central venous pressure. So we can simply say that the central venous pressure must be equal to jugular venous pressure plus 5 centimeter of blood. So if the central venous pressure has to be calculated, you measure the jugular venous pressure and add 5 centimeter of blood. So if the jugular venous pressure is 2 centimeter of blood, then the central venous pressure will be 2 plus 5, 7 centimeter of blood. That is how the calculation is done. The jugular venous pressure may be elevated in certain conditions. In any condition where the right atrial pressure rises. Right atrial pressure can rise in right ventricular failure, that is heart failure. It can happen in obstruction of the superior vena cava. The right ventricular pressure can increase in any kind of fluid overload when there is too much of water or blood in the body. It can happen when the heart is being constricted, so there is less space. For example, in cardiac tamponade. So these are the different causes where the jugular venous pressure may be elevated. Certain waves of the jugular venous pressure may be selectively elevated. For example, the A wave can become prominent when the atrium is contracting but blood is not reaching the ventricle. You know, A wave is caused by atrial contraction. Now imagine a chamber is contracting but blood is not going out, then the pressure will keep on increasing. So this will typically happen in cases of stenosis. For example, in early stages of tricuspid stenosis, in pulmonary stenosis, you can get a prominent A wave. A wave can become very, very high in complete heart block, where accidentally the ventricle and atrium can simultaneously contract. And such a very prominent A wave is also called cannon wave. You know, atrial contraction will be absent in atrial fibrillation. So A wave will be absent in atrial fibrillation. I typically mention early stages of tricuspid stenosis because in advanced stages of tricuspid stenosis, there can be atrial fibrillation. So instead of a prominent A wave, you may get a missing A wave. So early stages of tricuspid stenosis, any stage of pulmonary stenosis, and complete heart block are the causes of prominent A wave. In complete heart block, the wave is so prominent that it is known as a cannon wave. A wave is absent in atrial fibrillation. So these are a few of the things that we should remember regarding jugular venous pressure estimation. So let us end the session by solving the questions. A wave on JVP is caused by. Very good. It is caused by atrial systole. C wave is caused by. Yes, it is caused by bulging of the tricuspid valve. If the JVP, that is jugular venous pressure, is 4 centimeter of blood, what will be the central venous pressure? Wonderful. That will be 4 plus 5, that is 9 centimeter of blood. Cannon waves in jugular vein are seen in. Very good. The answer is B, complete heart block. And finally, why descent is caused by. Very good. It is caused by opening of the tricuspid valve. So these were the 10 episodes, the handpicked topics on cardiovascular system for season 1. Please stay tuned for season 2 and also suggest us topics that we can include in the season 2 of Medicrew Masterclasses.